All right. It's 6 o'clock. I know people are probably still going to trickle in, but I want to make sure we can get through um anything, everything, and have an opportunity to ask questions, and then potentially we could do the subclavian artery, but I feel like that's very ambitious. So thank you all for joining. I'm gonna share my screen. If you have any questions, Kate is here. She can answer questions in the chat. I know that once I have my screen shared, I'm not going to be able to see because I'm writing on my screen. So if you do have a question while I'm going through, please just like unmute yourself and ask it out loud or ask Kate in the chat. Um, I'm not going to necessarily stop a whole lot for questions throughout. I think it's important to kind of get through this. But I promise you, how I have it drawn out is a lot easier and prettier to look at for the most part, compared to what you guys have access to for the class slides. The only thing I want to say is just bear with me as I'm going through this because well, first and foremost, can you guys see my screen? Like it should just be like a gray page for OneNote. Are
Yeah.
you see that? Okay, great.
Yeah.
Uh, so just bear with me because the pad that I'm using, it's kind of finicky while I'm writing. So like it's not directly on my computer. It's like slightly off to the side. So just like I said, my handwriting might not be the best and it's a little finicky, but um that's all I have to say to start. So we're gonna dive right in. If people trickle in, that's okay. We're gonna be going over stuff throughout. So we're gonna talk about the brachial plexus today. You guys had an introduction to it this morning, and then we're gonna go over it today. Kate is doing something with the Arts and Medicine Club next week on Tuesday during lunch. So please go to her event and learn about the brachial plexus there. And next week we'll be dissecting it. So you guys will be getting a lot of brachial plexus the next couple of weeks, and that's a good thing because it's a tough topic and it's going to be many questions on your test. So it's good to kind of solidify it early. So we're going to dive right in. There's multiple sections of the brachial plexus. There's 5 different sections. And the mnemonic that I use to remember the sections of it is remember to drink cold beer. So I'll write that out really quick. Remember to drink cold beer. And the reason why is the first letter of each of those represents a certain part of the brachial plexus. So we have the roots, we have the trunks, we have the divisions, we have the cords, and then we have the branches. You guys are able to see what I'm doing, right? Like I'm not screwing anything up right now.
Yeah, we see it.
Okay, great. So before we dive into all the little nitty-gritty branches that everyone's probably so worried about because they go to the individual muscles, you need to build a foundation. You can't build a house without the foundation, right? So we're going to go over the basic, not basic, but the foundational structure of the brachial plexus, and then we'll go back to the beginning and add the branches as needed. So we're going to start with the roots. The roots are C5, C6, C7. Give me one second. I gotta go a little bit lower. I'm sorry. C8 and T1. The C5 and C6 roots are going to come together. We'll come back to that. C7 is just going to be its own little thing for a little while. And then the C8 and the T1 roots are going to come together. Okay, so that's not too bad. The C5 and the C6 root are going to come together and they're going to make the superior trunk. So that's the superior trunk. The C7 root is just going to continue on by itself and it's going to become the middle trunk. And then C8 and T1 are going to come together and they're going to make the inferior trunk. Okay. So that's not too bad. We're starting off nice and easy. So the superior trunk is going to divide and it's going to divide into 2 things. You have the anterior division and the posterior division of the superior trunk. And I'm just going to label it from here on out as A and P below because there's going to be a bit of a pattern here. So the middle trunk is going to divide into A and P, anterior and posterior. So we kind of have a nice little ring to it. It's anterior, posterior from the top. But then it would be nice if it was all anterior, posterior, but it's not. The inferior trunk is going to divide, and this time it's going to be posterior, anterior. This is like low, it's really low yield for them to test you on the specific divisions and like if it's an anterior, posterior, like, but you do need to know the divisions to kind of get where you're at later in the brachial plexus when we go into the cords and the branches. Um, so it's just kind of to get your foundation down, but I wouldn't worry too much about AP, or APPA, because when you see it on the body, you're not really going to see the divisions. It's very rare that you'll see, excuse me, the trunks in the body. What you will see is definitely the branches and maybe some of the cords in the body. Um, and then for written, they could test you on the trunks because there's some branches we're going to go over, and primarily the cords and the branches. But bottom line is, I just want to give us a foundation here. So I'm going to change colors now. So the anterior division of the from the superior trunk is going to combine with another anterior division, and it's going to make the lateral division, or excuse me, lateral cord. So these anterior divisions come together and they make the lateral cord. I might have to erase some stuff and move stuff around while I'm writing. Just keep that in mind. We're going to come back to this lateral cord for something in a second. Let me just change my color real quick. So the posterior divisions are going to come together, and all of them come together. So something like this. And they are going to make the posterior cord. So it's kind of nice. All the posterior ones come together to make the posterior cord. And then the last one that we care about is down here. The anterior division from the inferior trunk is going to come together with all the way up here from the lateral cord. And I know it looks like a mess because I'm drawing through stuff, and I'm sorry. But these two, let me erase that. I'm sorry, I don't like how I drew that. Those two are going to come together. Let me draw it real quick. Sorry, this pad thing that I have with me is really annoying. Oh, that's the wrong color. I'm sorry, guys. Oh, I'm making a mess here. I'll fix it. I'm so sorry. Okay, so we got the green. This lateral cord is gonna give off a branch down here. And these are gonna make two things that we'll talk about in a second. But this is just the medial cord. So I'm sorry, it should look prettier. If we weren't doing it on this OneNote thing, it would look a lot better, but hopefully the color coordination helps. Okay. Does anyone have any questions so far? This is the basic foundation of it. And now we're going to get into the branches and the sub branches. So this isn't that bad, right? You just kind of have to, as you're going through it, memorize these steps. So we're going to start with the first big branch. I don't want to overwhelm you
Quick
guys.
question.
Oh, go ahead. Sorry.
Sorry. For the inferior part, the posterior division, where does that go?
Sorry. I think I erased it on accident.
Oh,
That
okay.
comes up here and joins the other posterior divisions. My apologies. I think I hit it or I just failed to draw it before, but all the posterior divisions are going to come together to make the posterior cord. Okay. So the first branch, and depending on how deep we want to go today, because you guys haven't even had like upper limb yet, really. I don't, I could do another session, or Kate can go over this next week in her thing. But the point is that this page, when I send it to you guys, the notes that I have, it's going to be a lot more information than we probably go over today. So, anyways, the terminal branch for the lateral cord is the musculocutaneous nerve. And we'll talk about where that goes to in a little bit. But for now, we're just going to leave it at that. And if you're not following, like writing this as we're going along, I suggest that you do. Okay, so the posterior cord is going to have two branches that we care about. Um, or main branches, I should say. We're not talking about the sub branches yet. This is still part of the foundation, but we have the axillary nerve and the radial nerve. And the radial nerve is it's quite a pain because it has a lot of muscles that it goes to. But we'll come back to that in a little bit. And then the medial cord is going to give off in combination with the lateral cord. You can see the green coming from up there. It's going to make the median nerve and the ulnar nerve. Now, in it, this is not a great representation of it for the body. I mean, I tried my best, but on the body, this is going to make the musculocutaneous, the median, and the ulnar nerve are going to make, oh, what did I just do? Or is it going to make a big M like that? So on the body, that's how you're going to look for it. You're going to look for the musculocutaneous nerve piercing the coracobrachialis, and it's going to make a big M. And you'll see it next week. But and Kate can confirm it literally does look like an M. It's like this over the axillary artery. But this is sort of this is the M right here. But this is what it'll look like in the body more so, and you'll have some structures underneath it. But just for now, for lecture purposes, we'll keep it at this. Now I'm having an issue because I can't see my, oh, there we go. Okay. Get rid of that. Okay, so that's the foundation. It's not too bad, right? Just got to memorize how to get this foundation down. This is the big bulk of it, and now we're going to build upon it. I'm really sorry about it being like super cramped. I'm doing the best that I can. So we're going to zoom in so that we can add some stuff. We're going to start going into all the sub branches or the tiny branches that go to like the named muscles. So before we can even get into the trunks, and I might end up erasing this up here as we're working just to have some more room. But before we even get into the trunks, the roots, specifically C5, C6, and C7, give off an important branch before we even get into like the foundational stuff. So, and when I say foundational stuff, I mean the foundation of the brachial plexus, not the foundation exam. I'm going to use that term probably more than I should. But anyways, the C5, C6, and C7 branch are going to come together. So I'm going to draw it like this. So the C5 is going to give off something. The C6 is going to give off something. And then the C7 branch, or excuse me, root is going to give off something. And they're all going to come together. And they're going to give off the long, my thing would zoom in, the long thoracic nerve. Okay. And we'll come back to where that goes to in a second. We're just going to do baby steps, guys. When you're doing this, don't do it all at once. Do the foundation, add the sub branches, and then when you keep going back and reviewing the foundational stuff, add stuff as you go. That's just an extra way to review what you've already done. So C5, C6, and C7 are going to come together to make the long thoracic nerve. Again, I apologize about the crappy picture. I have a nicer version of this that I'm going to send to you guys afterwards. Okay, so the C5 root and the C5 alone is going to give off a branch. And if you guys have worked with me in lab today, or even so far this week, I've talked about this nerve a lot. And it's the dorsal scapular nerve. And we'll just leave it at that for now. But that comes from the C5 root. So that's it for the sub branches for the roots. If we want to move on to the trunk, so we have the superior, middle, and inferior trunks. The superior trunk is made by C5 and C6. That's the only one we care about for subbranches. The middle and inferior trunks do not give off subbranches, so we only care about the superior trunk. This is going to give off two branches. First is the suprascapular nerve. And then the second, it's called the nerve to the subclavius. I'm just going to call it the subclavius nerve for space. And that's it. And we'll talk about where these go to and what they do in a little bit. So that's it for the trunks. Now we're going to get into some, it's going to get interesting a little bit here. So I'm going to erase some stuff just to make some more room. I'm going to get rid of the cord up here. Just know that we're still, I'll put like a little C above it. And then I'm going to make this lateral part just a little bit smaller to have more room. I'm sorry if that's confusing, but so C up here for chord, and then I'm just going to put right here lat for lateral. So this gives off one branch. I guess I could have left it as lateral, but it gives off one branch and it's conveniently named, and it's the lateral pectoral nerve. So it's the lateral pectoral nerve. It has lateral in the name, so you know it comes from the lateral cord. This is where things get a little interesting. Where I have a mnemonic for the next two. This mnemonic for this one's, I'm not gonna lie to you, is inappropriate. So I'll tell you guys it, but just bear in mind that it's not a good one. I'll tell you it after we go through them. So there's the first one that comes off is the superior subscapular. And I see the chat going off. I can't see what the messages are, so I'm sorry if I'm not able to answer them. So the first one's superior subscapular. The second is the thoracodorsal. So those of you that have been working with me in lab, I probably grilled you on it a bunch of times today. And then the last one that we care about, we have a superior subscapular, so that means we have to have an inferior. So this is the inferior subscapular nerve. Okay, so this is my mnemonic. Um, it's not good. Like it's not good. It's not appropriate, but the way I remember this with my friends last year is STIs, so sexually transmitted infections, STIs are rad and proper. So superior subscapular is the S, thoracodorsal is the T, inferior subscapular is the I, R, the A is axillary, rad is radial, and then proper is for the posterior cord. I know that's terrible, but it helped me. It helped stick when I was the first year. Okay, and then the last bit of subdivisions that we have come from the medial cord, and there's three, and they're also pretty easy to remember. So we up here on the lateral cord, we had the lateral pectoral. If we just had a pectoral nerve, it would only be called pectoral. So because we have a lateral, we must have a medial. So the first one is going to be the medial pectoral nerve. And then these next two are actually cutaneous branches, meaning they do sensation to various parts of the skin and the arm. So we have the medial cutaneous of the brachium, which means upper arm. And then we have the medial cutaneous of the antebrachium, which just means forearm. So the way I remember this is the mnemonic that I came up with. It's M4U. So there's four things that start with an M, and then there's the one that starts with a U. You have the medial cord, medial pectoral, medial cutaneous brachium, medial cutaneous antebrachium. That's the four M's. And then ulnar is the one U. M4U. Okay, so we're making very good time here. We're gonna go into the muscles that they go to, and then we're gonna deal with these beasts over here. So we're gonna go back. If we recall, the C5, C6, and C7 root come together to make the long thoracic nerve. The long thoracic nerve innervates one muscle, and this is a highly tested topic. There's probably going to be one or two questions on your exam about this. I don't know why they love talking about this. It comes back in OMM as well. And this goes to the serratus anterior. So the function of the serratus anterior is it protracts the scapula. And what that means is it essentially keeps the scapula in place. You know, you're not actively protracting your scapula, but it's doing that against the scapular retractors to hold it in place. And the big thing that they test with this is the winged scapula. So if the common thing that they'll ask about if it's not trauma is oftentimes it's a patient that has breast cancer and they had like a a breast reduction surgery to remove the mass. They removed some lymph nodes that metastasized to the axillary region. And a common complication after that procedure is the long thoracic nerve gets damaged. So that's a fancy color, but I'm just going to write wing scapula. And the reason why is because you don't have this serratus anterior muscle to contract to keep it protracted. So your retractors, your rhomboids, which we're going to get to in a second, hold the scapula back, giving it that winged appearance. So, like I said, I'll have this all out for you guys in a better color coordinated manner, and I'll have the clinical correlates on there. But I think long thoracic nerve, wing scapula, goes to the serratus anterior, and it's common after breast cancer metastasis surgery, specifically in the axillary region. And the long thoracic nerve is, it becomes a long thoracic nerve when C5, C6, and C7 come together. Okay, so my favorite one of this week, for those of you that have worked in lab with me, I've tortured some of you with this nerve, is the dorsal scapular nerve. I threatened to call on someone randomly, but I'm not going to do that. So this goes to three muscles. We got the rhomboid major. We have the rhomboid minor. And then we have the levator scapulae. The functions of these are not bad. So for the rhomboids, they both have the same function. Think R for retraction. So they retract the scapula. And then the levator scapulae, it's pretty self-explanatory. It elevates the scapula. So think about shrugging your shoulders. So the dorsal scapular nerve is a subnerve or a subbranch from the C5 root, and it goes to three muscles, both rhomboid minor and major, and then the levator scapulae. Okay, so now we're done with the roots. We're going to the superior trunk. So there's two nerves that we care about, the suprascapular and subclavius. The superior trunk is made by the C5 and C6 roots. Once it comes together, it makes a superior trunk, and then you have two nerves that we care about. We're going to talk about the subclavius one first because I'm not even going to add anything. It goes to the subclavius muscle. No one cares about the subclavius muscle. It sits below the clavicle, hence the name subclavicle, and it literally just like keeps the clavicle in place. So we're not even gonna bother with that. But the suprascapular nerve is very important. And again, those of you that worked with me today in lab, we talked about the rotator cuff muscles. This nerve supplies two of the rotator cuff muscles. So it goes to the supraspinatus. I apologize about my handwriting. And it also goes to the infraspinatus. Just going to give us a little bit more room. I'm going to get rid of this middle down here. And let me know if I'm going too quickly, please. Like, tell me to shut up and I'll slow down. Because I know this is tough, guys. So this is the middle trunk. So the supraspinatus, or excuse me, the suprascapular goes to the supraspinatus and the infraspinatus nerves. The supraspinatus muscle, this is responsible for initiating abduction. So it's from 0 to 15 degrees, and then from 15 to 90, it's the deltoid, which we'll talk about in a little bit. And then from 90 to 180, it's the trap. They love to test this nerve because the patient presentation for a supraspinatus injury is pretty unique in that if you ask a patient to initiate abduction, so you ask them to, obviously patients may not know what abduction means, but you tell them to lift their arm from their side. What they'll do is they'll lean to the side that's damaged. They'll like side bend, if you will, for OMM's sake, to get the arm to the 15 degrees, and then the deltoid takes over. So oftentimes the question stem is going to describe what I just described. The other important thing is that this attaches to the greater tubercle, and I'll explain why that's important in a second, or an easy way to remember that. But the infraspinatus, another one of the rotator cuff muscles, it also attaches to the greater tubercle, and it is going to be for internal rotation of the, lateral rotation of the humerus. So external rotation. My apologies. external rotation of the humerus. I'll talk about the sits muscles or the rotator cuff muscles once we've covered all of them. So keeping it moving, keeping it moving. Just to recap what we've done. I know this looks like a lot because it's very cramped, but it's not that bad once if you guys were here in the beginning, you saw like you just keep adding layers, keep adding layers. So the C5, C6, C7 root gives the long thoracic nerve, which goes to serratus anterior, which helps with keeping the scapula in place. If it's damaged, you get a winged scapula. C5 also gives off the dorsal scapular nerve, which goes to three muscles, rhomboid major and minor, which help retract the scapula. It also goes to the levator scapulae, which elevates the scapula. Superior trunk, just think SS. It has three S's. So it has the suprascapular, which goes to the supraspinatus and infraspinatus, which does the supraspinatus does abduction, it initiates it, and then the infraspinatus does external rotation. And then no one cares about the nerve to the subclavius, but it's there. And then for the medial and inferior trunks, nothing to worry about. So if we go to the cord, the lateral cord specifically goes to only gives off the lateral pectoral subbranch. And that's obviously going to go to, well, I shouldn't say obviously, but it goes to pec major. So those of you that don't know, there's a pec major and minor. We'll get to the innervation of pec minor in a second. But the functions of pec major, it has a lot of them. So I'm going to try to abbreviate this, but it flexes the humerus. So think about bench pressing. Let me see if I'm going to get rid of the branches in the beer, if that's okay with you. And I can add it again later. It flexes the humerus. It abducts, so it adducts and medially rotates. My apologies. Adducts and medially rotates the humerus. My handwriting is absolutely terrible. Okay. It also is involved in drawing the scapula anteriorly. We're not going to write that. But it also extends the humerus, which may sound funny because it's a primary flexor of the humerus, but it extends the humerus when the humerus is flexed. So it also helps pull it back. I don't like how I wrote that. But the primary function is this here, the flex, the humerus. Okay, so moving on to these guys. We got the STIs are fun. STIs are rad and proper. You guys are gonna think I'm crazy, but whatever. As long as you remember, that's all that matters. So the superior subscapular nerve and the inferior subscapular nerve are actually going to come together. Not come together, but they help innervate the same thing. And it's the subscapularis, which is that muscle sits on the anterior side of the scapula. And it's also one of the sits muscles. So this is going to be on the lesser tubercle. If you remember the other two that we talked about go to the greater tubercle, and this one is for internal rotation or medial rotation. So that makes sense, right? For those of you that were with me today, if it's attaching to the lesser tubercle, that's slightly more anterior. When it contracts, it's going to pull the humerus because the lesser tubercle is more anterior medial. It's going to pull the humerus inside. So that causes internal rotation. And then while we're talking about the inferior subscapular nerve, we'll talk about where it also goes to, which is the teres major. Not minor, teres major. Minor is one of the rotator cuff muscles, major is not. Teres major is below the teres minor, which is why it's often confused with being a sits muscle or a rotator cuff muscle, but it's not. And this it does help with medial rotation, but it's primarily adduction, so adduction, with the lat. And then we're going to talk about the lat right now. The thoracodorsal nerve goes to the latissimus dorsi, but because we're running out of room, I'm just going to write lats. And then that extends the humerus, and also adducts the humerus. Okay, so just to recap before we move on, we got the lateral cord. It gives off the lateral pectoral nerve, which goes to pec major. We have the posterior cord, which is going to give off three sub-branches. We have the main branches, but the three sub-branches, the superior subscapular, thoracodorsal, and inferior subscapular. Superior and inferior subscapular are going to go to the subscapularis, which helps with internal rotation. And then the thoracodorsal nerve is going to go to the lats, which helps you do your pull-ups, your extends the humerus and adducts the humerus. And then we finally get to our last subdivision, which is the medial cord, which has, this is really easy. There's really only one that we have to talk about at this point, which is the medial pectoral nerve. So these are self-explanatory. This does sensation to the arm, to the medial aspect of the arm. This does sensation to the medial aspect of the forearm. The medial pectoral does two muscles. So we already talked about one, but for those of us that are hitting our bench press often, we got some big pecs. So the pec major needs two nerves to help it out, but it also goes to that pec minor that we were talking about earlier. And the pec minor just helps stabilize the scapula. It does help in flexion and all that stuff, but it can help with respiration as well. But it's primarily what they want you guys to know right now is stabilizes scapula. Does anyone have any questions for me? Now I can answer some questions before we get into some more deep dive stuff. This is the bulk of it, or the bulk of the foundational stuff for the brachial plexus. I know we covered a lot, so does anyone have any questions? Looks like someone's raising their hand. I can't see who, but if they want to just start chatting, go ahead.
Okay, so for my question is, you said pec major is innervated by two nerves.
Mm-hmm.
Function is still the same, correct? So
Say that
like,
again?
so the function is still the same.
Yes, the function is still the same.
So if you like cut one of the nerves, it'll still be able to do its job.
Yep, exactly. So that's an important point where let's say you damage the lateral pectoral nerve, the pec major is still able to help you flex your humerus, so do your bench press, but it's going to be weakened. So you can still do it, but it will be weak.
Thank you.
Yep. Okay, if no one has any questions after that, we can dive in to the major branches. It's There's a lot. I don't want to do more than we have to because you guys haven't gotten to the forearm yet, but you have to think all these all these nerves are going to muscles in the upper extremity. So everything you do with your hands and fingers and your forearms and your arms are all going to be related to these nerves here. So I'll dive into it. Just keep in mind that it may cover some stuff that we're not going to necessarily talk about until next week. But it'll be a nice little head start, if you will, for lecture. I'm not going to go into anything crazy details, but I'm just going to do some of the main branches. So the musculocutaneous nerve gives off two branches that we care about. It has the lateral cutaneous nerve of the arm. So we have the medial cutaneous nerve of the arm. This is where the lateral cutaneous nerve of the forearm, of the forearm is. And then this is sensory. So I'm going to put up here sensory. And then it also gives off a motor branch. The motor branch is still just called musculocutaneous nerve. So I'm going to write motor. It doesn't have a different name. And this goes to three muscles. Everyone knows this muscle. It's their favorite muscle, the biceps brachii. It also goes to the coracobrachialis. And then it goes to the brachialis. These are all primarily elbow flexors, but the bicep brachii can help with supination of the forearm, which we can get into in a little bit. The big thing about this that they love to test about is obviously the functions of these muscles are important, but they love to talk about anatomical relationships in lab and in lecture exams. And the reason why that's important is because the musculocutaneous nerve pierces the coracobrachialis. So that's when we get into lab and you guys are working with me, or whoever the TAs, they all have been taught this by every professor. Your landmark for working through the brachial plexus on the cadavers is you find the musculocutaneous nerve first because it's piercing the coracobrachialis. And the coracobrachialis is like a little tiny arm or a muscle underneath the bicep on the upper part of the arm. So once you find the coracobrachialis with the musculocutaneous nerve piercing it, you can trace that M that we were talking about to get the rest of the branches that we care about down here. So that's it for the musculocutaneous nerve. We're going to go into the axillary nerve. Where is my blue? Okay. So the axillary nerve, it has a sensation component as well as a motor component. So on the top, I'm going to do sensory, and then on the bottom, I'm going to do motor. So this is motor, this is sensory. The sensory component, it goes to essentially think about the muscle. It goes, we'll do motor first. So actually, motor, it goes to two muscles. Just want to erase this really quickly. It goes to two muscles. We have the deltoid, and then it goes to the last of our rotator cuff muscles, teres minor. So the deltoid, we all know it's like our lateral radius. It does abduction from 90 to 180. And then teres minor helps with the external rotation of the humerus along with the infraspinatus. So there's two muscles that do the external rotation, teres minor and then infraspinatus. So I'll just write external rotation. And then the sensory is really easy. The sensory just does sensation to where these muscles are at. So it does like the lateral part, posterior lateral part of the deltoid. So not too bad. I'll just write posterior / lateral. I'm sorry, say that again. Yes, this I did write 90 to 180. That is perfect. Good catch. It is 15 to 90. I'm sorry. I was thinking about the trap for some reason. Yes, you are right. Thank you. Good catch. And if I'm making mistakes like that, guys, call me out. We're going through a lot here, but yes, it is 15 to 90, and then the trap will take over after 90. So good catch. Okay, so the radial nerve, the radial nerve is a beast, and I'm very reluctant to do this right now because there's a lot going on with the radial nerve. So if you guys want me to, I'll do it, but there's a lot going on with the remaining nerves that we have to do.
Do it.
Do it. We're gonna dive in. We got like 15 minutes left, so I'll do it, but just know that we're getting into some crazy stuff here. So the radial nerve, and actually I'm kind of glad that we're doing this because they don't teach it to this is the one thing I have a qualm with anatomy is that they don't really show you where all these nerves come from, like in conjunction with all the other ones. So we're gonna go through it. And if you guys need another review in person or whatever, like we can schedule a Zoom or I can come in person. We can talk through this stuff. But so the radial nerve has it has 3 divisions. But I'm gonna draw it in a specific way. So I'm gonna draw it like this. So you got the superficial radial nerve. And then I'm going to leave this as radial for now because the radial nerve innervates some muscles. But it also still further divides, if that makes sense. So we're going to talk about the superficial radial nerve first. So the superficial radial nerve is sensory. So this is the sensory part of the radial nerve. And this is going to go to the posterior aspect of the humerus. It's really posterior and lateral. So this is sensation. It also does the dorsal aspect of the hand. but commonly what they'll test you on for that is just radial nerve. Once we talk about the median and ulnar nerve, we'll talk about more of the sensations of the hand, but we're just going to talk about radial right now. So radial goes to a few specific muscles, and then once it passes those muscles, it's going to divide at specific parts, at specific areas within the arm. So the radial nerve, once it travels down the shaft of the humerus, it like wraps around it. So that's like a common clinical correlate, or how they'll test you, is that if you have a humeral shaft fracture, the nerve that's most at risk is the radial nerve. So while it's traveling down the posterior aspect of the humerus shaft, it's going to innervate the muscles that it passes through, and then some distally. So the main one is the triceps. It's also going to do a tiny muscle in your elbow called the aconius. We're going to skip over the actions for now because this is just already too far ahead, but the aconius does help with extension of the elbow. And then it does two more. These two more are primarily in the forearm. So you have the brachioradialis, which is often confusing for some students because the brachioradialis helps with flexion of the elbow. If we recall, all the flexors of the elbow were done by the musculocutaneous nerve. This is one of the exceptions. The brachioradialis does flexion of the elbow, but it's not innervated by the musculocutaneous nerve. Or excuse me, flexes the forearm. And then finally, this is going to be all foreign to you guys, but you have the extensor carpi radialis longus. I think for now, once we do the last two branches, I'm not going to go into the specific muscles because that I just feel like is going to be, we'll talk about the median and ulnar nerve and then go from there. But this also gives off two more nerves, which are going to do the remainder of the forearm muscles. So the two that you have are the deep radial nerve and then the posterior interosseous. So this one right here is I'll put a star next to it, is the primary. It does most of the muscles in the forearm. It does most of the extensors of the hand. We're going to come back to that in a little bit. I want to get to some of the other nerves while we still have some time left. Okay, so the median nerve is also a beast. Its sensation is to the ventral and lateral aspects of the lateral 3.5 digits. So I know that may not make any sense to you guys right now, but it does your thumb, your pointer finger, and your middle finger. Those 3 digits and like half of your ring finger on the ventral side of it, so the palmar side of it.
Are you writing on the screen? Oh.
I'm writing right now.
Okay.
So sensory. And then it goes to the 3.5 palmar digits. And then I should specify the lateral digits. Okay, and its motor, we're going to go over here, is also a lot. And again, I have it more organized than this in a prettier document for you guys. It's just hard with the situation we're in. So its motor, the median nerve itself before it divides, and I'm not going to go over this because it goes over a ton of muscles that it's just too much to talk about right now. But the median nerve before it divides into its terminal branches is going to innervate a ton of the flexors in the forearm. And we can go over that at another time. But this is going to give off two nerves. Today we're just going to talk about the remainder of the nerves. It gives off, remember there was a posterior interosseous up here from the radial. It gives off the anterior interosseous. And then it gives off the recurrent median nerve. Okay, so we're going to leave it at that for now because like I said, I just don't want to give you guys, I really feel like I gave you guys too much with this right now. We should have just stuck to the nerves. But so the median nerve is going to give off its sensory. It's going to do part of the palmar aspect of the hand. And then it has two other branches that it divides in the forearm. It goes to the recurrent median and the anterior interosseous. But the median nerve itself, before it divides, is going to innervate a bunch of muscles in the forearm. Okay, and then lastly, the ulnar is not quite as bad. It has two divisions that we care about. It has its sensory, so I'm going to write sensory, and that is going to be for the remaining digits on the fingers, the remaining digits on the hand, on the palmar side. So the median nerve does the thumb, the thumb, pointer, and middle finger, and then half of the ring on the palmar side. And then the ulnar nerve is going to be doing the ventral and dorsal, so palm and back of the hand of the last two digits. So the remaining one half of the ulnar nerve, or the ring finger and the pinky finger. I'm going to show you guys my hand in a second because I have a way to remember it. But the ulnar nerve is going to innervate one muscle, and then it's going to go to the deep ulnar nerve. And that's going to innervate the rest of the muscles in the forearm that weren't done by the median nerve, and then it's going to do a lot of the intrinsic hand muscles. So I know we covered a lot. There's one more thing I want to show you while we're on the topic of the median, ulnar, and radial nerves. And I'm going to stop sharing my screen for 1 second, and I'm actually going to turn on my camera. So this is how I remember. Are you guys able to see me right now? Yeah, it looks like you can. Okay, so this is how I remember the median, radial, and ulnar nerve sensation in the hand. A little premature, but that's okay. So you're going to make a gun with your hands. I know that's probably inappropriate, but you're going to make a gun like this. On the palmar side of the gun, so you got like the cock, the barrel, whatever, this is where the trigger would be. On the palmar side of the gun, on this part here, this is all median nerves. So the palmar side of the thumb, palmar side of the first finger or second finger, palmar side of the middle finger or third finger, and then it does half of the ring finger on the palmar side. The part where my fingers are down, so my ring finger and pinky finger, that's all ulnar nerve. Okay, both. That's why it's down, because it's doing both, palmar and ventral side, or the palmar and back of my hand. But when you flip it to the other side, ignore this because that's all ulnar. The rest of it's radial nerve. So just to recap, hopefully that wasn't confusing, but you make the gun. On the palmar side, the first digit, second digit, third, and half the fourth are done by the median nerve. The remaining half of the ring and the pinky are all, both the palmar and the back, done by the ulnar nerve. And then everything else over here for the barrel and the trigger of the gun on the back of your hand is radial nerve. I hope that makes sense, but that's how I remembered it last year. I'm going to go back to sharing my screen for 1 second. The other thing that I wanted to briefly talk about, because it's a highly tested topic in anatomy as well as OMM and PD, is the sits muscles. So the sits muscles are your rotator cuff muscles. There's 4 of them. So I'm just going to write out sits for a second. These 3 here have the same attachment. So this is supraspinatus, distal attachment, I should say. Infraspinatus, I'm just going to leave it like that. And then it's the teres minor. All 3 of these attach at the greater tubercle of the humerus. This is important. So if this is your humerus like this, it's a terrible drawing. Like this, it's sitting in the scapula like that. This is going to be the greater tubercle right here. Okay. Supraspinatus is going to be above the scapular spine, and it's going to come over and attach right here in the greater tubercle. If this contracts, so it's going to tighten, it's going to pull this way, that's going to initiate the arm going up like that, because it attaches at the top part of the greater tubercle. The infraspinatus, so if this is the spine here of the scapula, you have the supraspinatus above it. That means you're going to have the infraspinatus here, and then you have teres minor down here. They also attach to the greater tubercle like this. So if they contract, they're going to pull the arm back like that, and that's going to cause external rotation. And then I'm not going to draw because it's going to be confusing, but on the other side of this, so this is the posterior side of the scapula that we're looking at. On the other side, it's coming out like this, attaching to the lesser tubercle is a subscapularis. So when that contracts, it's going to pull this way, and the arm is going to turn in like that. So you have your sits muscles, supraspinatus, infraspinatus, teres minor, and then this is your subscapularis. The SIT and sits, they all have the same attachment, distal attachment, I should say, to the greater tubercle. And I just thought this would, look at the bones in lab, look at the bones on the skeletons in OMM, whatever. I just thought this would help kind of relate how they move, because I feel like that can be confusing. Does anyone have any questions for me? I know we covered like so much right here, but I have a very pretty, nice version of all of this. The only other thing I really wanted to discuss is the two major areas of damage that can occur, because it's another highly tested topic. And then when you get into your second year, it's going to come up on your board. So, I'll just do that before I take questions because I got a few minutes. So the first one is up here. It's in the superior trunk. I'm going to write down here, and that's called Erb's palsy. And that's a superior trunk injury. Okay. So the superior trunk is going to present with something called the waiter's tip hand. But the way I like to remember it is birds, it'll make sense in a second, eating herbs. And really all we care about is this part of the birds. So B is for biceps. The I is for infraspinatus. The R is for wrist extenders. The D is for deltoid. And the S is for supraspinatus. So think about it. If you have damage to the superior trunk, think about everything that's behind it that could potentially get damaged. You're going to get your musculocutaneous nerve, which is going to do the elbow flexor. So that's the biceps. It's also going to directly impact these nerves here. So you're going to lose the supraspinatus and infraspinatus because the suprascapular nerve is damaged. You're also going to get some radial nerve and axillary nerve impact. It's going to be weakened because you're going to get contributions from other parts of the brachial plexus, but you're going to have weakness with the deltoid because that's done by axillary, and you're also going to have weakness with all the extensors in the arm. So that's for a superior trunk injury, Erb's palsy, birds eating herbs. And then the last big one that's board testable and then for your classes is Klumpsky's paralysis. So that's an inferior trunk injury. That I'll write over here. So Klumpke, however the hell you say it. That's going to present with claw hand. So that's like a buzzword for you. And that's going to impact the ulnar and median nerves primarily. So if you know what these guys innervate, you know what muscles these guys innervate and what they do for sensation, you know what will be damaged. So it's everything all over here. So you're going to lose the medial pectoral. You're going to lose sensation in the arm and the forearm medially. And then you're going to get weakness or loss in the muscles that the median and ulnar nerve innervate. So those are the two big ones. Now they can ask you, with the last few minutes here, they can ask you questions like, oh, you're no longer able to abduct or lateral raise your arm from 15 to 90. What nerve is damaged? Axillary. They'll ask you throughout the test like specific nerves that could be damaged. They'll either ask you outright or you need to know the location of the main nerves. So musculocutaneous nerve is in the proximal humerus, pierces the coracobrachialis. The radial nerve is going to be going down the shaft of the humerus. If you get a humeral shaft fracture, they can test you on that. The axillary nerve wraps around the surgical neck of the humerus. If you get a proximal humerus fracture by the head of the humerus or at the neck, that could impact the axillary nerve. So that just to give you a glimpse of how to start thinking about how they're going to ask you questions about these nerves. All right, so we got 2 or 3 minutes left. Does anyone have any questions for me?
Yeah,
Sorry.
one quick question.
Sure.
So you could basically damage the ulnar nerve, but still have intrinsic hand movements if your radial nerve is still functioning.
Well, so the radial nerve isn't going to do any of the intrinsic hand muscles. The intrinsic hand muscles are going to be done by the median and ulnar nerves. And so theoretically, you could, because the median nerve does get some contributions from the lateral cord, but you're going to, for Klumpsky's paralysis sake, you're going to lose intrinsic hand muscle, because it's a pretty severe damage.
Got it. Okay. Thank you.
And if you guys have any questions, please just say them out loud.
Hello, thank you for the explanation. On the exam day, did you like draw it like when you like were trying like to figure out questions, or like you like tried to memorize it like before?
So I did not draw. I never really used my scrap paper. I tried to memorize this beforehand, rather than write it all out on the piece of paper. Now, that's just how I did it. Some people, they tried to do what you just suggested, write it out on a piece of paper, as soon as you get the scrap paper, just essentially splash it onto the page. That's fine too if you feel like you have to. But if you're able to remember it well enough to draw it on that piece of paper when you get the scrap paper, I feel like you're able to remember it off the rip. But if you need that visual and they're asking you questions and you want to go through the diagram, there's no problems with that.
Thank you.
My recommendation when you're going through this, don't try to do all this all at once with all this nonsense. Like we did in the beginning, start with the foundation, do the roots, do the trunks, the divisions, the chords, the branches, and then slowly add each subdivision, and each time add a little bit more. There's no way you can go all the way across and do all the motor and the function and stuff like that. You just got to slowly add to it as you learn it and feel comfortable with it. Does anyone else have any questions?
I have a question. Can I please see like the birds, the Erb's palsy thing again?
Yep. Let me share that screen here. Okay, so Erb's palsy is a superior trunk injury. So it's going to be up in this area here. And it impacts the biceps, so the flexors, the infraspinatus, the wrist extensors, the deltoid, and the supraspinatus.
Okay, perfect. Thank you.
All right, guys, we do have to log off because the physio office hours are right after this. Thank you for staying on. And if you guys have any questions, please feel free to email me. And yeah, we'll chat soon. Hopefully this was helpful, guys. Good luck, everyone.
Thank you.